Hey everyone, and welcome to Providing Culturally Responsive Neurodiversity-Affirming Therapy. My name is Jessica Kitchens, and I am a private practice therapist located in Fayetteville. I have two private practices. I have one that's just myself, and then I have my Allied Collaborative that has a couple of other therapists, and this is where I offer neurodiversity consulting and training. I specialize in neurodiversity and cognitive disorders, substance use, addictions, and play therapy. I am a mother of 5 children, ranging in ages from 9 to 22, and I also recently became a grandmother for the first time with a grandson. I call myself Lolly. My husband is Pop. My youngest, Ridley, was diagnosed autistic at the age of 4. Honestly, at that time, I thought she had what we call pragmatic communication disorder, since her pragmatic speech was primarily the only issue that I noted to be a struggle at that time. During her evaluation, I noted there was a lot of questions that I actually could answer yes about myself, and that was when I first started looking into what I later learned to be high-masking adult autism. I was officially diagnosed in 2022, and I was also diagnosed with generalized anxiety disorder. It's also quite frequently a common comorbidity. It's been a long, eye-opening road of self-discovery and self-acceptance, which has further led to advocacy and education. I am not alone. There are numerous other autistic therapists whose lived experience has been a positive in many ways in working with neurodivergent clients. A little bit about me. I am a lover of knowledge and research, and besides my master's in counseling and marriage and family therapy, I also have an MBA and will be starting a PhD in the fall of this year, 2023, in change leadership for inclusion and equity at the University of Central Arkansas. My goal is to research neurodiversity in business and other things related to neurodiversity while there and after. Let's talk a little bit about the importance of inclusion, because it's becoming more and more important in our daily lives. Whereas diversity training for therapists has grown exponentially in the last few years, there's been a significant lack of neurodiversity-affirming training. As therapists, it's important for us to make sure that we include all types of diversity in our practices. Neurodivergent clients are not a rarity. It would be impossible for all therapists to avoid this population, considering it encompasses a variety of different needs. We need to make sure as therapists to stay up to date on what constitutes ableism and provide an all-encompassing, accepting, and nurturing environment for all clientele. These are our learning objectives for today. I'm not going to read them to you. You can definitely read them yourself. But I want you to think about if you think your therapeutic practice is neurodiversity affirming. The bad news is this training at some point will probably challenge that, but the good news is all neurodiversity-affirming therapists have been challenged and continue to grow in this topic. It is constantly evolving as advocacy grows. More and more neurodiverse adults or neurodivergent adults are speaking out. And I personally have learned the most from neurodivergents themselves and not from professionals, sadly. And even with the little bit that we have to cover on this topic today, it's just going to be an iceberg. It would take a good all-day training to cover a good portion of it. It is my hope that I can at least touch on the important highlights. So what is neurodiversity? Neurodiversity, or ND, refers to variations in the human brain and cognition, for instance, in sociability, learning, attention, mood, and other mental functions. Also defined as the range of differences in individual brain function and behavioral traits, regarded as part of normal variation in the human population. It is used especially in the context of autistic spectrum disorders. The infinity symbol, particularly the rainbow infinity, represents the greater neurodiversity movement. Many autistic adults prefer the infinity symbol, especially red or the AU's gold, instead of the blue, as their preferred symbol representing acceptance, not just awareness. This is something to keep in mind as April is around the corner for us. Their arguments include that the infinity symbol represents that the autism spectrum is not linear, that each autistic individual has endless possibilities and often untapped potential. The infinity symbol represents the fact that autism is not a disease and thus it does not need to be cured. They do not like the puzzle piece due to the argument that autism is nothing to be puzzled about and we are not looking for a missing piece. Autistic individuals do not need to be solved like a puzzle. They need to be accepted and celebrated for who they are. They also argue the puzzle piece is infantilizing. This is something to remember if you market yourself a neurodiversity-affirming therapist. Autistic adults who have been in advocacy will call you out. With that being said, there are those autistic individuals who are not bothered by the puzzle piece. If that is the case, that is their choice, and we are also not there to correct it. The point in knowing about the infinity is to understand when we use the puzzle piece that it carries a negative connotation to many in the autistic community. It is for our caution to be aware of this. It is often confusing to distinguish between neurodiversity and neurodivergence. That's why we're going to discuss some basic terminology here. I myself still get quite confused at times, but to be fair, terminology, pragmatics, and semantics are often something of a struggle for me. You can read these, but I'll go over the big ones. About neurodiversity is the diversity of human minds, the infinite variation in neurocognitive functioning within our species. It includes neurotypical as well. A neurodivergent person is defined as one whose neurological development and state are atypical, usually viewed as abnormal or extreme. The term was coined in the neurodiversity movement as an opposite for neurotypical. And ableism is defined as a discrimination or prejudice against individuals with disabilities. I'll also direct you to a really great 15-minute video by Joel Schwartz on more of these definitions and on the social disability model and on the neurodiversity paradigm as a whole. Let's discuss language because it matters. This is mostly specific to autism. Let's talk about autism versus with autism or has autism. Adult autistic advocates generally prefer identity-first language to person-first. This is something that was not addressed in most of our culture classes in graduate school. Many adult autistics have embraced their identity and prefer autistic to person with autism. I find generally it is parents who prefer to use person first when discussing their children. But there are more parents who are now embracing the term autistic after learning from many adult autistics why they prefer it. I love these infographics because they get right to the point. The most important thing being the individual chooses what they prefer. We do not correct them. I have seen therapists and parents on social media try to correct this terminology and it never goes over well. I will also add, as a therapist that's looked for a therapist that's neurodiversity affirming, when I come across a website of a therapist that states they work with autism and they don't use identity first language, I immediately suspect that they are not neurodiversity informed. Also, it is very pathology laden. I know they are not neurodiversity affirming. Considering there is a whole population of individuals that are very keenly aware of the neurodiversity paradigm, they also are looking for specific language in a website. Not a lot of people know that Sir Anthony Hopkins was diagnosed as autistic in 2014. Here you see him rubbing his hands, which is actually something he has said he does quite often. It is a stim. At this time of his diagnosis, he was actually given it as Asperger's. Something to keep in mind about Asperger's is that it is not typically seen as a neurodiverse affirming label. The idea of functioning labels is often looked down on in general to the fact that it is so-called high-functioning individual could actually be struggling more internally than a supposed low-functioning individual. Even the term Asperger's is named after the Austrian physician who coined the term, who actually was found to have worked alongside the Nazi regime. I will let you read up on that if you like, but many autistic adults are not fans and will call you out. But something to remember is the term itself is no longer in the DSM, and all diagnoses of autism and pervasive developmental disorder are under one autism diagnosis. But they do put levels to it, 1 to 3, mild, moderate, and severe. But just remember that even if you get a level 1 diagnosed individual, they can still internally struggle and their daily functioning can still be very difficult, often more than a level 2 or 3. Generally, the best way to address functioning is with support needs. You can use the 1 to 3 levels if you are in a clinical setting with other professionals, but honestly, I don't even like to do that. Because again, language matters. Other specific language issues include intellectually or developmentally disabled, which are not the same thing. We prefer that to MR, or mentally retarded, which is outdated very much. Also, non-speaking or minimally speaking is preferred and not nonverbal. Also, supportive education, not special education. This is a harder one when you have a child with an IEP, but just know that language is moving towards the supportive education. Public schools are still using special education, so I do understand the difficulty in that. And also, communication versus behavior. Again, these are our breakdowns, and we'll cover the 4 learning objectives. And we're going to talk about the types of neurodivergence. Most therapists know what most of these are, but a few you might not know are dyscalculia, hyperlexia, and dyspraxia. Dyscalculia is a learning difficulty that affects an individual's ability to do basic arithmetic, such as addition, subtraction, multiplication, and division. Adults with dyscalculia often take longer when working with numbers and may be more prone to making mistakes in calculations. Hyperlexia is when a child can read at levels far beyond those expected for their age. Dyspraxia, also known as developmental coordination disorder, or DCD, is a common disorder that affects movement and coordination. Dyspraxia does not affect your intelligence. It can affect your coordination skills, such as tasks requiring balance, playing sports, or even learning to drive a car. And just in case, dyslexia is a learning disorder that involves difficulty reading due to problems identifying speech sounds and learning how they relate to letters and words and the decoding of them. Also called a reading disability, dyslexia is a result of individual differences in areas of the brain that process language. And a lot of the therapies to treat it actually use speech therapy as a part of it. Also, Tourette syndrome, or TS, is a neurological disorder characterized by sudden, repetitive, rapid, and unwanted movements or vocal sounds called tics. Tourette syndrome is one of the group of disorders of the developing nervous system called tic disorders. Here is where it can actually get really confusing. Most advocates and researchers of neurodiversity and neurodivergence include acquired disorders like anxiety, schizophrenia, and PTSD, while others do not. Regarding PTSD, the belief that trauma-related brain changes are a form of neurodiversity. DID, or as you can see here, dissociative identity disorder, and BPD, or borderline personality disorder, are both trauma-related and therefore are also argued to be neurodivergent. The confusion lies in the difference in natural brain differences compared to those that are made different by something else, such as trauma. Regardless of what classification they do fall in, it is important to recognize that these individual brains are different and are not within the realm of neurotypical. Therefore, they are neurodivergent. It is also important to be aware that with stigmatizing these individuals can be harmful. For example, BPD has developed a very negative stereotype of which has led many therapists to refuse working with them. It is also a spectrum of symptoms of which can often be treated and addressed with a great compassionate therapist. Regardless if it is or isn't a neurodivergence, compassion is the key to working with these individuals and understanding that due to nature or trauma, their brains are different. These are just a couple of neat different graphics on neurodiversity. The first was created by livedexperienceueducator.com. Sonny, I believe, is her name. And the second was by Valentine Occupational Health. And just so you know, ABI is acquired brain injury. Sonny has some really great stuff if you ever follow her on social media. I believe she is on Instagram and Facebook. She's on different social media. One thing to keep in mind if you are going to be a neurodiversity affirming therapist is neurodiversity affirming and LGBTQIA plus affirming go hand in hand. There are various research articles out there identifying a correlation in individuals who identify as LGBTQ plus as being more likely to be neurodivergent. In the largest study to date on these topics, the team at the Autism Research Center and University of Cambridge used an anonymous self-report survey to study the sexual activity, sexual orientation, and sexual health of autistic adults. Overall, 1,183 autistic and 1,203 non-autistic adults and adolescents aged 16 to 90 years old provided information about their sexual activity, sexual orientation, and medical history of STIs. These are just a few of the highlights of that research. The article can be found at the end of this PowerPoint. And just to kind of highlight some of these things, autistic adults and adolescents are approximately 8 times more likely to identify as asexual or other sexuality than their non-autistic peers, and we have definitely seen that in our practices. Autistic males are 3.5 times more likely to identify as bisexual than non-autistic males, whereas autistic females are 3 times more likely to identify as homosexual than non-autistic females. And lastly, autistic females were more likely to be sexually active, more likely to identify as asexual, bisexual, and other sexuality, and were less likely to identify as heterosexual. Now we're going to jump to the importance of a neurodiversity affirming lens. Let's talk a little bit about the problem with the pathology paradigm. Autism advocates with this view include both a small but significant minority of autistic adults and large majority of parents of autistic children, but contain a higher percentage of parents when compared to those adopting the neurodiversity paradigm. These advocates believe that medical research is necessary to address the autism epidemic, reduce suffering, and provide the best outcomes for autistic individuals. In addition to etiological research, other areas of focus may include biology, diagnosis and treatment, including medication, behavioral and psychological interventions, and the treatment of coexisting medical conditions. Advocacy groups that focus primarily on medical research include Autism Speaks, Cure Autism Now, Former Autism Research Institute, National Alliance for Autism Research, Autism Coalition for Research and Education, the Autism Science Foundation, and its predecessor organizations. It is important to note that all neurodiversity affirming advocates are opposed to these organizations. Neurodiversity advocates are opposed to medical research for a cure, believing that it will lead to eugenics, and instead support research that helps autistic people thrive as they are. Advocacy groups that focus primarily on acceptance and accommodation include Autism National Committee, Autism Network International, Autistic Self-Advocacy Network, and Autistic Women and Non-Binary Network. So what exactly is the problem with the pathology paradigm? Well, it focuses on disordered impairments, mainly communication and social interaction compared to social norms. Its perspective of harmful dysfunction. The atypical behaviors of these individuals are considered a detriment to social and professional success and should therefore be reduced or eliminated through therapy. If you look up some very old Autism Speaks commercials on YouTube, and they're not hard to find, sadly, they're very, very sad. And it basically makes autism to be this very horrendous thing. It's really, really sad. And it's one of the primary reasons where autistic adults do not agree at all with Autism Speaks. The Therapist Neurodiversity Collective, which sadly mental health therapists are yet not included, they mostly take speech and OT, or occupational therapists, has a lot of great resources, and here is just a quick infographic on the pathology model of therapy for autistic individuals. Let's talk a little bit about ABA, or Applied Behavioral Analysis. It is a form of behavior therapy that is widely seen as the gold standard for treating autism. It is often the first prescribed by psychologists with an autism diagnosis is given. However, autistic people and those in the neurodiversity movement strongly disagree. The neurodiversity movement does not view autism spectrum disorder as something that needs to be treated or cured. On the contrary, ABA focuses almost exclusively on correcting behaviors of autistic children, molding them to fit the norm. It is rooted in historically aversive and abusive tactics and is harmful in the long run. And most of its proponents do not include autistic people themselves. The founding father of ABA is generally considered to be Ivar Lovaas, a Norwegian-American psychologist and professor at the University of California, UCLA. He believed that autistic children were not even people, as he once said, "You see, you start pretty much from scratch when you work with an autistic child. You have a person in the physical sense. They have hair, a nose, and a mouth, but they are not people in the psychological sense. One way to look at the job of helping autistic kids is to see it as a matter of constructing a person. You have the raw materials, but you have to build that person." That's just awful. It is also important to note that Lovaas was also substantially involved in the Feminine Boy Project, which has strong connections to what is today known as gay conversion therapy, which is illegal for us as therapists to even do. Psychologist George Rakers, a key figure in the Lovaas conversion therapy and co-founder of the notoriously anti-gay Family Research Council, used Lovaas's techniques to treat so-called deviant sex role behaviors in male children. The discussions of ABA and its opposition in neurodiversity-affirming therapy could actually take hours in and of itself. There is research on the increase of PTSD symptoms on autistics exposed to ABA. The findings to the Kupferstein research found that nearly half, 46% of the ABA-exposed respondents met the diagnostic threshold for PTSD, and the extreme levels of severity were recorded in 47% of the affected subgroup. Respondents of all ages who were exposed to ABA were 86% more likely to meet the PTSD criteria than respondents who were not exposed to ABA. Adults and children both had increased chances, 41 and 130% respectively, of meeting the PTSD criteria if they were exposed to ABA. Both adults and children without ABA exposure had a 72% chance of reporting no PTSD. At the time of this study, 41% of the caregivers reported using ABA-based interventions. It is important to note as mental health therapists that ABA is a behavioral therapy and rarely does not care or get to the root or the why of a behavior. And many of the behaviors they label as problematic are in fact healthy stemming that helps the individual cope or self-regulate. Behaviorism misses a lot of the sensory needs that are important to note when working with autistic individuals. Many feel a child acting out is simply a behavior problem, when that is the opposite of what is going on. There are so many other factors to look into. And remember, behavior is communication. Another thing I just have never quite understood is this therapy alone is recommended to be 20 to 40 hours per week, which I don't even know how anybody can fit that amount of any kind of therapy in, and I honestly don't think any therapy should require that much, with the exception of physical therapy for a very acute time period. Research has shown, obviously, that the PTSD symptoms are increased. This Kupferstein is actually a woman, and I've actually come across her on some Facebook groups. I did not realize who she was other than when I recognized her name. I asked her if she was the one because I didn't think the name was very common, and come to find out she was. So I'm actually impressed that I was able to come across her. She is pretty prevalent in some research groups. They also label atypical play as inappropriate and limits free play. And again, anything that takes 20 to 40 hours, you've got kids going to school and then they're going and doing this after school. They don't have any time for free play. And so that's limiting a lot of their progress right there. So let's talk about the neurodiversity paradigm. The neurodiversity paradigm actually views neurodiversity as a natural and valuable form of human diversity. It offers an alternative to the main approach of behavior therapy as a treatment. It's akin to the social disability model. However, one key aspect of the neurodiversity paradigm is understanding that societal and social norms are often ableist or rooted in discrimination. Many of the things that behavioral therapies treat are things that we as a society has decided are not societally or socially acceptable. But the reasoning behind this doesn't actually make sense. Let's use eye contact, for example. I hate it. It's uncomfortable. It's not natural to me. I can do it in session and when I generally talk to a friend or family. But if I'm passing someone or if I'm in a drive-through, it is not something that I do. Yet the pathology model would state that I need to learn to do it and that the more I do it, the more it will come naturally. Sorry, but no. I can mask and do it, but it will never be comfortable, and honestly, it is not important. Another example that is used in education is called quiet hands, and calm bodies are what's needed for learning. When in fact, forcing hands and bodies to be still in classrooms can often make it harder for some children to learn. Some children actually learn better when they are moving or fidgeting. My daughter learned her letters at 2 years old, watching alphabet YouTube videos while jumping on a mini trampoline. No one taught her. She just watched, jumped, and absorbed. Many teachers are starting to learn about this concept, and there are still many that are using some old thinking that is making it harder for their students to learn. Many businesses are actually starting to get more into the notion of by adding bouncing balls as chairs to office desks and allow fidgets while their employees are working. So this is not just a child thing. I have had to write letters to employers about how to better accommodate their workers by allowing such things as dimmer lighting or other avenues to help with sensory overstimulation. Again, as a therapist or neurodivergent individual, I will look for affirming language on a website, and so are many clients. The only clients you attract with pathology language are usually parents who want you to change or fix their children, which is not something we do, or individuals or adults who have been viewed as broken and need to often be treated, and a therapist to fix them. We aren't doing much good as therapists if we continue to have them see themselves in a negative light. These are just some of my favorite organizations to follow, whether it's on social media or on the internet in general. Most can be found on Facebook and LinkedIn. I follow a lot of these organizations that are leading the way in neurodiversity in business, which again is what I'm looking to do research in during my PhD. Neuroclastic is awesome. They're fighting to the fact that this is even a thing. There is literally a place that uses shock treatment, not the kind we're talking about with depression that literally is just minor. No, these is significant shock treatment on individuals who are autistic, and they're usually like adolescent and adults, and their families have put them there, and it's very aversive, and they have called it out to be torture. And so the place, I forgot the name of it, Judge Rothenberg place or whatever, initially had threatened to sue them if they didn't take their language down. Well, Neuroclastic kind of started a grassroots effort, and their following raised enough money to fight this. And not only has the company not been able to sue them, but they're close to getting shut down. And the ABA is even starting to talk as if they're going to not allow that shock treatment under their guidelines as well. It's a big thing, but obviously follow Neuroclassic to get more information on that. And these other two are just amazing organizations to follow as a whole. And if you hear anything in the background, that's probably my daughter humming. Next, we're going to talk about the traits of neurodivergence. So let's talk about my practice statistics. And for the purpose of this section, I will focus mostly on the traits of autism and ADHD, since those are the ones that most often are misdiagnosed in our line of work. We see many of the others that are generally fairly obvious to note, such as OCD, schizophrenia, and PTSD. And there is a whole generation or more of individuals who have misdiagnosis for these, but are ending up in therapy for other issues and comorbidities. Most of these comorbidities are easier to identify. So my practice is mostly an identity-owned practice. Many individuals seek me out already having a diagnosis, or are self-identifying or self-realized, which is valid, and wanting to move towards an official diagnosis, many of which end up receiving an actual diagnosis from a psychologist after meeting with me or one of my therapists. Many have told me they looked for a specific therapist that was neurodiversity affirming. So yes, it is important to indicate on your website in some capacity. I can attest as an individual, again, seeking therapy, I too am looking for this, and it is quite rare to find in Arkansas that advertise that they are part of a practice being neurodiversity affirming. So please start if you are interested in researching this more. Okay, let's look at these statistics. So, and these have actually probably changed since I did these last summer. It probably have gone way up since then. But these statistics are the total number of clients for the first 3 weeks of August of 2022. It is a total of 37 clients, 17 or 46% of which are either officially diagnosed with autism or are seeking a diagnosis and are considered self-diagnosis. Most of which do many months of research by the time they reach me. 22 or 59% individuals are diagnosed with ADHD or are soon to be tested for it. 13 of the 37 or 35% have both autism and ADHD. I understand my practice is probably relatively higher than what is considered typical. However, some of these individuals were initially seeking therapy for substance use related issues or significant depression and anxiety, which often can be comorbidities of these, or cause from masking, which I will touch on in a bit. It wasn't until further evaluation that many traits were detected to indicate one or both ADHD and autism. If you think you don't work with this population, you are mistaken. Many of these also meet the criteria for OCD, dyslexia, and other common comorbidities, and often require special therapy such as speech or auditory therapies along with reading specialists. So what are some possible signs of autism in undiagnosed individuals? While these are mostly seen in adults and teens, some of these can be seen in children as well. Some of these you might not notice in session, some you might. Often you will catch glimpses of these in their conversations, and then you might think to ask about them more. Let's talk about sensory signs. They may show in the forms of picky eating, chewing nails, or skin picking, which is also called dermatillomania, chewing, rubbing, and touching things for comfort, need for deep pressures, and need for weighted blankets, which are awesome, sensitivities to lights and busy environments. Hello, Walmart, I hate that. Aversions to certain textures or fabrics. Difficulty managing certain types of noises, also called misophonia. Difficulty settling your brain at night, getting overwhelmed in certain environments, etc. I have every one of these. Communication signs may show in the forms of avoiding small talk. I absolutely hate it. Avoiding eye contact, difficult understanding metaphors or jokes, which is not as common as people think though. I mean, some autistics really love their puns. They love metaphors. Some things might take a minute for me to understand, but I mean, overall, I can understand sarcasm and whatnot. Preference to written forms of communication such as text and emails. We hate the phone. May struggle with fast conversations. Auditory processing challenges may show in preference for subtitles on TV. I cannot hear without my subtitles. May be blunt or often seen as rude. Often considered shy or are extremely introverted. That is me. May have odd or quirky communication mannerisms and may info dump on certain topics that they find enjoyable, even on the topic of neurodiversity. Also, I have every one of these. And some more behavior signs might include fidgeting, tapping, or other repetitive behaviors. Rigid thinking, struggling in unfamiliar or overstimulating environments, struggling to adjust to new situations, adherence to routines, emotional dysregulation, maybe in situations that seem relatively unproblematic, meltdowns, self-harming such as hitting their head when upset, anxiety that's high, and rumination that sometimes does not fit the situation, intense focus on certain topics, and substance misuse as a means to cope with sensory overstimulation, emotional dysregulation, and social situations overall. Social signs may include constantly rehearsing interactions and conversations. I do this all the time. Thinking in black and white or very literal. I actually am very much a gray thinker. Very few things in my very black and white. So this is one area that I do not really have that, but many autistics do. Having few close friends or acquaintances, struggling with others breaking the rules or seen as having a high moral code. I have definitely seen this. In fact, I feel like many autistics have a really high justice principle. Feeling as though you blend into others around you, we're the wallflowers, or avoiding events that will have crowds. Absolutely. I like to go to a great concert, but I have to do a lot of prep before I go. As an autistic therapist, one social sign I have always hated trainings were the dreaded words, let's break up into small groups. I also hated group assignments in school. That and the fact that I generally had to overcompensate for others who didn't do their part. Something that is a bit of a misnomer when it comes to stereotypes or misconceptions of autism is many autistic individuals have extremely high empathy, although they might struggle with theory of mind, which is different. It is often called cognitive empathy, but I don't even like that term for it. It's the trouble that many have with seeing how something might significantly or specifically bother someone when they didn't necessarily see it as hurtful themselves. This is often why they may be blunt or come across as rude. But many autistics often have intense somatic empathy or an autonomic physical response to others' emotions. This is often called an empath. And yes, not just autistics have this, but many of them do, and they feel very intensely for others. But their response might not be necessarily what you expect, and they might not outwardly act at all. But this doesn't mean that they aren't feeling for you. They definitely do, and sometimes those feelings are uncomfortable or confusing to them. Many people know about the double empathy problem, but some people don't. And for those of you who do not, it is often the result of individuals having different theories of mind. This suggests that when people with very different experiences of the world interact with one another, and they will struggle to empathize with each other, it is usually a breakdown in reciprocity and mutual understanding that can happen between people with very different ways of experiencing the world, both of which can have very high empathy. So let's talk a little bit about diagnosing. I did mention earlier in the presentation about self-diagnosis or self-realization as an autistic, and it is a valid realization. The reason behind this being that many individuals, by the time they come to me or they're being tested, have actually spent many hours looking through the DSM criteria and various online self-administered tests. Many have gone back and forth about having imposter syndrome, second-guessing themselves, but ending up getting to a point that they can no longer refute it. It is also important to note that official diagnosis is a privilege. Even in our area with various psychologists, only few do autism testing. One I referred several clients to no longer does the testing, which is too bad. I felt he did a really thorough job and enjoyed reading his results. And not all accept insurances, or many at all. If one has Medicaid, for example, the only option is to pay out of pocket if you are an adult. If you are a child, there is the Schmeeding Center and the Dentist Developmental Center. But the wait can often be around 18 months or longer for both of those. And honestly, I have disagreed with assessments that have been given before on children from the Schmeeding Center. And not just about autism. I feel they missed the mark on a lot of things. Also, many psychologists' testing is outdated and not valid for adults. And even fewer are neurodiversity informed and how autism presents in high-masking individuals, especially females. Those psychologists tend to deny diagnosis because individuals come across as high-functioning and they don't see under the iceberg of how it might be debilitating at times. I have yet to refer a client for testing and them not receive a formal diagnosis. But I don't just refer to anyone. I choose psychologists that I have read their testing and feel they not only use adequate testing measures, but they take in a good portion of the intake and a person's lived experience. I have had one come to me having a testing exam with one local already scheduled, but it wasn't a psychologist. And in fact, I don't even know why they were doing testing because they were not supposed to be testing. And I felt like they missed the mark big time. And so obviously, for many obvious reasons, I do not refer to them. My own experience was similar to trying to find a therapist for myself. The psychologist that I referred to knew me too well to my referrals, and I felt that they might have a bias considering I am the therapist always referring clients to be tested. And so I fear bias, and in case you cannot tell, I went so far as to schedule with a psychologist in Missouri that works well with high-masking females. Due to PsyPact, I could actually be tested by her. Unfortunately, it was 7 hours away, and she couldn't take my insurance, and the cost was going to be very high. But I was going to make it work. Again, note the part about privilege. But it was going to take 6 months of waiting to get in. But I had to schedule it. Then I got a new client that was going to be tested by a new psychologist in the area who got her in very quick because they were new. And they took her insurance, which was also my insurance. I waited until she went through the process to get an idea of what the psychologist was like because this individual presented very much like myself. And she reported an accurate diagnosis and relayed her experience, and I went ahead and reached out and got myself scheduled and was relieved to find out actually how smooth that process went with her. I felt validated and was glad to be able to add another tester to my referral list. And the good news is she takes several insurances and has a fairly short wait list and has told me her desire to hire more testers and eventually take Medicaid. It helps that she is also neurodivergent and neurodiversity informed. So let's talk about possible signs of ADHD in undiagnosed individuals. Signs of ADHD might include inability to deal with stress, carelessness, and a lack of attention to detail, continually starting new tasks before finishing old ones, poor organizational skills, inability to focus or prioritize, continually losing or misplacing things, forgetfulness, restlessness, and edginess, difficulty keeping quiet, and speaking out of turn. Blurting out responses and often interrupting others, mood swings, appearing to be unable to listen to or carry out instructions. Irritability and quick temper, extreme impatience, and taking risks in activities. There are a lot more, including struggles such as time blindness and other executive functioning issues. I wanted to touch on something that I learned at the Archon conference a while back. One of the breakouts I went to was on ADHD. And the presenter mentioned that there is a theory that those with ADHD have more fluid in their brain that is electrically conductive, which is why ADHD individuals' attention is on many things. I found that really fascinating, and it actually makes a lot of sense. Also, I love the term, the Maori term for ADHD, Neurodiversity-Affirming, which means attention goes to many things. Their term for autism is Takawatanga, which means in their own place and time, or owns time and space. They seem to grasp neurodiversity better than most. Also, when I was doing my own testing, I told the psychologist to go ahead and test me for ADHD as a rule out or rule in, because I honestly didn't know. I had some of these symptoms, like I could walk into a room, definitely forget what I went in there for, and not ever remember it. I'm actually very organized, and I can hyper-focus on things, so it wasn't that I had all these. I definitely just had several of them, but I do know that there is an overlap. But individuals can definitely have both. It did come out that I was not ADHD. In fact, the tester said that I had one of the cleanest marks on the test, which was very surprising. So all the symptoms that I do have of ADHD are because of my autism. Just something to keep in mind. Also, since there is an overlap at times with PTSD symptoms and autism and ADHD, it is not uncommon to miss these traits. I think it is great that we are teaching schools to be trauma-informed. We just need to also include it in the training that sometimes it's not trauma, but ADHD or autism, or even trauma with one. I feel like the schools might get a good grasp at catching ADHD, but a lot of times it's the hyperness. I feel like especially females, sometimes they still can miss the things. But autism, we're still very far away from being able for schools to accurately identify it, unless it's an obvious thing. But here, I'll let you all read those. I don't necessarily need to tell you. These are some really good graphics on the overlaps of both of those. Now we're going to talk about masking. Great infographics from 21st Century, and there'll be more on the second slide as well. A lifetime of masking can often present its own issues. Often it is done unknowingly. Unlearning it is not easy. I will recommend a book on this later for this exact thing. Over time, it can lead to shutdowns or meltdowns. I have written a book on specifically autistic shutdown from my own point of view, but also on addressing it. I wrote it in 5 weeks. When you talk about info dumping, I info dumped a book in 5 weeks. And because shutdown and meltdowns is included into it as well, is very, very problematic with almost every autistic individual that I work with. And it also addresses masking in that book as well. So I do not know when that book will come out. I'm very happy that I was able to finish it as I did. I'm hopeful that it will be very, very helpful to a lot of people and professionals as well. But speaking of meltdowns, these can be seen as tantrums or labeled as a breakdown, but they are definitely not the same. I liken meltdowns to a train that is derailing. Its purpose is not to get one's way. Once it starts, it needs to run its course, but with support and compassion, it can be greatly reduced. Masking is done at every age. I did it as a child, not even realizing that's what I was doing. Trying to unlearn it can be rather difficult and fear-inducing. Many individuals come to counseling due to the burnout of many years of masking. This can often be confused with depression. Many mask by using substances such as alcohol to cope with the energy required to consistently do it day in and day out. This is how several individuals have made their way to me. Once other signs of autism are present, then I'm able to open up that conversation. It often leads to them finally understanding themselves in a way that they never were able to before. Many are finally able to give themselves grace and understanding for that feeling of being different that they had their whole life. And that is why it is important to come from a neurodiversity-affirming place and not one that's pathologizing. Substance misuse can also be a means to cope from high social anxiety that often comes with autism or the impulsivity of ADHD. Both of these populations have an increased risk of substance-related issues and or process addictions such as gaming, pornography, and gambling. That's a whole different training on itself. But the point is to keep in mind that it can be anyone that comes to you for whatever reason, and undiagnosed autism or ADHD can be an underlying issue. And sometimes once it is identified and pieces start fitting together for them, they can often begin to change their perception of their life, and that insight can bring a lot of healing. I know for me, I had to look at my whole life and my childhood with a whole new lens. Some of it brought about some anger, but the clarity that came with it did present a lot of peace. And I'm still trying to learn to unmask. It's a process, I'll just say that. So let's talk about the techniques and modalities best for this neurodivergent population. These are the modalities in particular: positive psychology, attachment theory, person-centered theory, which is my baby, solution focus, my other baby, acceptance and commitment therapy. And there are definitely more, but these are definitely the ones I will highlight today. So why these? Positive psychology has the potential to enhance quality of life and emotional well-being by enabling neurodivergent individuals to focus on strengths and providing hope for the future. A strengths-based approach is important in working with this population. Regarding attachment theory, despite what very old and incorrect theories suggested, autism is not caused by parents' inability to attach to a child. Goodness, they were very wrong way back then. While an insecure attachment style can often have overlapping symptoms, they are not the same thing. I could probably present on the similarities and overlaps in a training all on its own, but for the purpose of today's training, I will stick to why attachment theory is ideal for this population. To the point, autistic individuals are capable of forming secure attachments. While they may be at a somewhat higher risk to develop insecure attachments, there are clear benefits to secure attachment, particularly with autistic individuals. According to the Maliva article, just like anyone else with a secure attachment style, securely attached people who are autistic tend to be more socially skilled, empathetic, and popular in general. What's more, autistic children that are found to be securely attached had greater language abilities. They also initiated more interactions with their caregivers during playtime than their insecure counterparts. Also in line with attachment theory, autistic children who have their emotional needs met through consistent and responsive caregiving are more aware of and better able to respond to the emotional needs of others. What's more, their actions towards others during times of distress demonstrate empathy. However, these traits were not found in insecurely attached children with autism. My own parenting style sided more along what is considered the crunchy attachment parenting style. This was long before I even knew I was autistic. I probably aligned with this more because my own attachment with my mom was secure, but I naturally drifted towards extended breastfeeding, co-sleeping, non-cried out, even as a very young mom of 20. These seemed more natural to me. Person-centered approach is my primary modality. To me, it has always made the most sense in working with a variety of struggles and issues. And according to the article by James, it makes the most sense because person-centered approach is to see the individual with a disability or condition as equal. It is simply to give the individual the same respect, opportunities, and rights that every individual has. An important thing to focus on when expressing the person-centered approach is not to see the limitations someone may have, but to see them as differences and as something the individual can overcome with support. I also utilize a great deal of solution-focused therapy. It draws from aspects of positive psychology theory and is a great modality with this population as it draws on the conclusion that the client is the guiding expert of their life. It is very collaborative in identifying goals, which is ideal for working towards autonomy, which is very important with this population. That autonomy can look very different to that of a neurotypical individual, but can be met in various ways. It also aligns with clients already having the resources and strengths to solve their problems. Acceptance and commitment therapy, also known as ACT, is not a modality that I have been trained in. It is one many neurodiverse-affirming therapists have praised. I do ideally want to get trained in this, but for right now I'm not utilizing it. For those of you who are, something that you will appreciate, According to Dr. Johann Pankey, ACT adapted to autism seems to be able to reduce stress and improve well-being in adolescents and adults with autism. If you haven't noticed yet, there are many theories and modalities that can work with this population. Some others and even techniques like EMDR, which is good for trauma, eye movement desensitization and reprocessing, or brain spotting, IFS, internal family systems, EFT, emotion focus therapy, CBT, although be careful, we'll just address that in a minute, CCPT, child center play therapy, and OT play. Chances are most of you have noted a theory that you already practice. And honestly, most theories can probably be aligned to a degree. Being strength affirming is neurodiversity affirming. Also, as with any therapy, a trauma-focused lens is necessary, probably more so with autism in particular. Identify your typical traumas is important, but also note that with autism, some atypical things may bring about trauma responses. For example, SPD or sensory processing challenges can often bring about trauma reactions, particularly loud environments. Also, especially for late diagnosed individuals, having unreasonable neurotypical expectations placed on them can often be overtaxing and can produce trauma responses. EMDR and brain spotting are great tools for many neurodivergence. There are EMDRIA approved trainings specific to autism. IFS is great because it is not pathologizing. According to Oswald, the IFS model has helped reduce anxiety and worry, increase self-esteem, improve mood, and create a more hopeful outlook on life. And yes, EFT and CBT are also great theories that can be used with this population. However, CBT is probably the most ideal in working with OCD and those problematic behaviors. And however, please note that if there is a comorbidity of diagnosis of autism with OCD, there can be issues with immersion therapy or exposure response prevention, as it can often be traumatizing to the autistic individual. It's not always bad, but it's definitely one you had to be using caution. There are some autistics that feel CBT wasn't a good fit for them. Ideally, it is important to research any of your modalities or techniques that you use to make sure there aren't exceptions or warnings to keep in mind. And if a client isn't responding well to a certain modality, we as therapists need to take or change our approach or refer out if we're not capable. Honestly feel that should be the case when working with any specific population. And yes, for our play therapists in the room, CCPT is still ideal with this population. While I'm not 100% CCPT, my play therapy incorporates it about 90% of the time, regardless of if it's with a neurodivergent or not. OT play was created by Dr. Robert Jason Grant. He's amazing, and he's done great various trainings on working with neurodivergent children. And on his website, you can even find some that are free. Again, whatever modality is used, a strengths-based approach should be utilized. Speaking of Dr. Robert Jason Grant, he has written some great workbooks in the past year that are specifically neurodiversity affirming. I had the privilege to take part and share my lifetime SPD experience for his book on understanding sensory differences. This was before my official autism diagnosis. My sensory story is located on pages 33 through 37. These particular guides are great if you work with children with sensory-related issues, autism, or ADHD. There are a lot of worksheets that he includes in these books. If I have some, if you know me and you want to look at these books before you buy them, you're more than welcome to, but they're not very much, so I highly recommend everybody get them if they can. And his website is very, very informative. If you have work with children and you work with neurodivergent children, I highly recommend looking at his website, as there's definitely a lot of books and trainings, many of which are online and are self-paced. And he goes around to a lot of places, even overseas, to do OT play trainings. So that is definitely something that you can get certified in. I am on the OT play advisory board this year, so it's definitely something that I do recommend. Regarding DBT as a therapeutic modality in working with this population, there are plenty of advocates and articles citing that it is effective with this population. However, I do need to point out that a recent article in August of 2022 from Mad in America by Rebecca Donaldson had described various trauma survivors reporting that they felt DBT was harmful to them. That reference is also located in the references at the end of this training. While I am not a DBT provider, I did come across this workbook written by fellow neurodivergent therapists that I've helped had some great worksheets. And this is that Sonny Jane Wise that I was talking about earlier, that lived experience educator. She's amazing. She posts videos and stuff that are just hilarious, but this is a really good workbook. Again, I have it if you ever see me and want to look at it. Also, I have this Managing ADHD workbook for women. Both of these are very new. The ADHD book, I feel, is a great family resource, and you can give them the book to read even if the client doesn't want to read it, because it gives them some insight into understanding the ADHD brain in women. There are also first-person stories and some great descriptions within it. Here's some other great favorite books of mine to read both as a therapist, parent, or neurodivergent. The Explosive Child is a great book for parenting a child with a PDA or pathological demand avoidance profile using a collaborative approach. Honestly, I think it's a great book on parenting most children. The Unmasking Autism was my first book read to myself as a newly diagnosed autistic adult. I found it very informative and liked it a lot. It also provides a lot of insight in general to the late diagnosed autistic. Devin Price, the author, who is a psychologist, did not know that they were autistic when they were a psychologist. They were even diagnosed after they became a psychologist. Well, I find that just very fascinating. This Different Not Less by Chloe Hayden is amazing. She is that Australian actress, really young, and she's on some Netflix show. I have not seen the show, but the book is amazing, and it is also on Audible. I actually read that right as I was making this presentation, and I added it later, and it's probably my favorite thus far. Another one that just recently came out, and I have not included it into this, and it's more of like the parenting side of things, and I've only read part of it, but it's been a great resource thus far, is at My Hill to Die On, and it has 2 authors. So I really feel that that's another one that I'm probably going to add to this as well. If you happen to be on social media at all, or if on Facebook, I highly recommend joining this Neurodiversity-Affirming professional private group with this link. It is a breakoff of the original Neurodiversity-Affirming therapist group that is currently on pause because of some of the issues from the group founders. It will be back. They're just trying to iron out some drama. You will learn a lot, and you are always free to ask questions if you run into specific client issues or have questions on books or other needed resources. There is no way that one therapist can know everything related to neurodiversity. It is vast. It is growing. Staying up to date with the latest research, resources, and trainings is important, regardless of what population you serve. Groups like this can often help with connecting to many of these. There are several others you might be interested in finding them. I can also point them out to you if you ever want to know. Sometimes they're more specific to the type of professional that you are. This one is a pretty broad one. So sadly, due to time constraints, I am only able to touch on some of the major neurodiversity affirming skills discussed today. I could easily do a 6 to 8 hour training on this. This is just another non-exhaustive list of some of the other key items that are important to note in this paradigm. Feel free to take a screenshot, take a picture, or write them down to research a bit on your own. I'm trying to kind of, make up this PowerPoint for my own therapist, or maybe even a manual for the therapists that work for me, to include this knowledge on these items as well. If I had time, I would go over each and every one of these, but I will go over a few that are very important since I haven't touched on them yet. One being spoon theory. Social and emotional energy is measured in spoons. An autistic individual can start the school day with a full drawer, which may be only half as full as a neurotypical, or with some of the spoons already used up in dealing with the demands of getting to school or work, or even taking a shower. Depending on various factors such as whether they slept, if their clothes are itching their skin, if their routine was changed, or any number of other seemingly incidental events, they may be starting the day with, say, only 5 spoons instead of 10. And some people start in the negatives because they used up all their spoons the day prior or even the weeks prior. They need to start using their spoons, and they don't have them. Each set of instructions, each set of work demands, each time they have to organize themselves or follow a complex set of instructions or cope with change, and each social interaction may cost an individual a spoon or more. If there are sensory sensations that are overwhelming, then another spoon is used up in regulating and keeping calm. If the person has to work in a group, more than 1 spoon may be needed. Break times are not relaxing. Another spoon or 2 is used up in coping with the social interaction, noise, and lack of structure. Some people manage to have a spoon by shutting off. It might save a spoon. Taking the time to be alone so that they can cope with the next set of demands. Many neurodivergent autistic adults are running on a negative deficit of spoons, depending on the day. Another one is RSD, the rejection sensitive dysphoria. This is not a formal diagnosis. It's common, this and PDA are common in the UK and Australia. It's starting to make its way over here in the US. I feel like it's going to pick up speed, but right now we're still very behind those countries. So definitely you want to read up and learn about these more. Again, it's not a formal diagnosis, but rather one of the most common and disruptive manifestations of emotional dysregulation. It's a common but under-researched and oft misunderstood symptom of ADHD and autism, particularly in adults, but I've seen it in teens. RSD is a brain-based symptom that is likely an innate feature of these brains. RSD is not thought to be caused by trauma. Dysphoria is the Greek word meaning unbearable. Its use emphasizes the severe physical and emotional pain suffered by people with RSD when they encounter real or perceived rejection. Note the perceived, criticism, or teasing. The emotional intensity of RSD is described by sufferers as a wound. The response is well beyond all proportion to the nature of the event that triggered it. The excruciating pain of RSD is often beyond description. Individuals describe the intensity of RSD as awful, terrible, catastrophic, or devastating, but they cannot verbalize the quality of the emotional experience. Individuals suffering from rejection-sensitive dysphoria may exhibit the following behaviors. Sudden emotional outbursts following real or perceived criticism or rejection. Withdrawal from social situations, negative self-talk and thoughts of self-harm, avoidance of social settings in which they might fail or be criticized. For this reason, RSD is often hard to distinguish from social anxiety disorder. Low self-esteem or poor self-perception, constant harsh and negative self-talk that leads them to become their own worst enemy. Rumination and perseveration, relationship problems, especially feeling constantly attacked and responding defensively. I wasn't quite done with that. The next big one is pathological demand avoidance, or PDA. This is something that I do have. I did not know what it was until one day it just hit me when I was reading up on something. But it's basically what it says, a pathological demand avoidance. But I do believe that we have missed the mark big time. I feel like oppositional defiant disorder is this. ODD misses the root. And I feel like it's a label slapped on kids a lot of times, and it doesn't necessarily identify what's really going on. PDA, much like RSD, is not a formal diagnosis. But it's a series of explanations of what's going on and their reactions. To me, it's an amygdala response to a demand, much like if the demand was a trauma. They have a fight, flight, freeze, or fawn response. When I was a child, this was a fawn response. I would definitely try to do everything that was required of me to try to avoid someone demanding of me. As an adult, this has turned into me staying ahead of the demand. And this is where I do things like be my own boss to avoid people demanding anything of me. I don't like how I feel when somebody uses an authoritative tone or if they're very, very harsh with me. I can avoid most demands, but I cannot avoid it all. What gets me is like if I get pulled over by a cop, it hits me like a ton of bricks. My amygdala reacts much like a threat of literally a predator. I have to talk myself down now that I know what's going on. And even though I'm having adrenaline and cortisol, all that stuff shooting through my body, I have to tell the cop, because I cannot control my tone, that the reason I'm talking this way is because I'm not mad at them, that I'm mad at myself. And it could be something completely like I didn't realize I had a tail light out. And I don't get pulled over a lot, so this is luckily not a thing that I have to address a lot, but it's something that I definitely have to be aware of. And I feel awful if my family isn't with me because they get embarrassed. Because before I knew what this was, I wouldn't necessarily get in trouble, but I would talk to police officers in a tone that I probably shouldn't have. But what happens is, children, teens, adults that have this might respond in an aggressive manner. Actually, most of them probably respond in a, I will not do what you tell me to do. That's why it comes across as oppositional defiant. They don't do it. That's a freeze response. And many of them have that response. I have an amygdala fight response, and that's where my tone comes out. And I really have to battle, and I have to be mindful of this. There's so much information on PDA, and I follow several various PDA individuals online, and ironically, all of them are based in the UK and Australia. But they're very informative. If you need information on those, I would be happy to share those later as well. Alexithymia is not that an individual cannot feel an emotion. They have trouble identifying what they're feeling. They definitely feel them. And so sometimes, especially if it's more than one emotion, if they're feeling, they get it convoluted, and it's hard to just necessarily put the label on it. I struggled with this when I had to pull my youngest out of school and homeschool her. I didn't know if I was making the right decision, and I couldn't identify literally what I was feeling. And so I literally pulled out a long list of emotions and went down. And the only one that I could find that was even close to how I felt was ambivalent. And I still don't even know if that necessarily fit. Stimming, I think we addressed that a little bit. That's, coping mechanisms that are done. You'll hear my daughter humming in the background. That's her best stim. She likes to move and she likes to hum. My 16-year-old, who's probably an undiagnosed autistic as well, very genius, probably bordering on savantism. He also hums a lot as well. So we recognize that's just how they cope. It doesn't cause any harm. Sometimes I have to tell her to turn it down just a bit, but overall I think it's unproblematic, and it's actually good for them because it helps actually target that vagus nerve, which helps cope in general situations. We did do this double empathy problem, auditory processing differences. I think we hit it on that a little bit, but I probably could go into depth about that later. There are different learning styles. I'm a kinetic learner. I learn by doing. I also, it's kind of a combination. I need to see it, I need to hear it, but I also need to do it. The doing aspect, I learn more things by doing it. And if you give me a set of instructions, I'm not going to learn it. You show me how to do it, I will learn it, and I'll probably remember it the best that way. I am also, when it comes to written and verbal expressive, I am what we call written expressive. I have a hard time necessarily coming up with the right words, and pragmatics are a struggle for me. That's become more of a problem since when I was 18 I had seizures, and it actually ruined a Navy career for me. But The seizures that I had at that time seemed to cause some permanent damage with aphasia, and I still do struggle with identifying words at times that I need to. And I'm just really blunt about it. I'm like, I have a hard time coming up with a certain word, and I'll describe it, but I literally it'll elude me significantly. Also, obviously, I think most people know what the accommodations are. Those are usually for educational purposes or during work or career environments. This is where I need to definitely do more research, because I feel like this is where we as a society culturally are struggling the most. And advocacy and education aligns with that. Again, the emotional dysregulation, meltdowns, and shutdowns, I am addressing that in a book. It's a 170-page book. So obviously I could probably make a training on that for, an all-day training on that. It is probably the biggest issues when it comes to an autistic's a lived experience that they struggle with is the shutdowns, also called burnout. There's the same thing. But emotional dysregulation and meltdowns are very much related to those. So I think that's generally the ones that are probably the most you probably don't know about. Any of the others, you're free to ask me, and I will definitely have an info dumping session with you anytime. But that is all I've got today, and I will hopefully present more of these issues later. Are you ready?